o'clock Central Time. Hello, everyone. Let's begin. I'm Laurel Steinmanoff. I'm the Executive Director for Quality and Innovation at the Urgent Care Association, and I'd like to welcome you to our second COVID-19 Town Hall. I also need to let you know that contrary to a few of our promotional messages, which were in air, this event, like all of our town halls, does not carry CME credit. So I apologize for that error, but we wanted to make sure you knew that up front. Our facilitator today is Dr. Sean McNeely. He is a CUCM fellow, former UCA board member and president of the board, as well as he currently serving as the immediate past president of the College of Urgent Care Medicine. Dr. McNeely will be joined by some esteemed panelists in urgent care medicine, who he will be introducing momentarily. We'd also like to acknowledge the support of today's town hall by Menarini Silicon Biosystems. As COVID-19 continues to surge through the country, antibody testing is more crucial than ever to track and understand the spread of the virus in our communities and to protect the most vulnerable. Menarini has a 10-minute, easy-to-use EUA authorized rapid test, and you can learn more information on that test and gain insights into how SARS-CoV-2 may be driving endothelial dysfunction in blood vessels, kidney, and other systems. You can go to their website, siliconbiosystems.com. We appreciate their support for today's gathering. A few housekeeping items before we begin. There are actually two ways to ask questions, depending on how you are accessing this webinar. For today, the interactive session, please put your questions into the chat box on the Zoom menu right in the middle, usually at the bottom of your screen, and we'll answer them either as we're going or most likely at the end. If you are watching the recording via a recording, you can use the question feature in the UCA 2020 app to submit questions, and we'll share them with our experts and get back to you with the answers. At the end of our session, we'll have a short evaluation. We'd appreciate your feedback and so that we can continue to improve. The evaluation for those watching the recording is included in the UCA 2020 app. We'll also forward a copy of the recording to all of you with us today. So with that, I thank you for being here, and I'm going to turn it over to Dr. Sean McNeely.
Welcome, everyone. Thanks for being here. This is our second town hall. Hopefully you had the opportunity to listen to our first one. We had several excellent panelists that will be working with us today. We do have one disclosure. Dr. Toscano serves as a UCA's clinical content coordinator. Next slide, if you would, for me. So the list of panelists today, we have an excellent group. Dr. Chris Chow, who will be talking about testing who and what, is one of our board members of the College of Urgent Care Medicine. Dr. Toscano, I mentioned his title before, we'll be talking about testing principles in general, and flu, COVID, and strep. What were we going to do this fall? Dr. Bogle, who is the president of the College of Urgent Care Medicine, will be talking about care of the patient. And Dr. Tracy Davidoff, who is the vice president of the College of Urgent Care Medicine, and we'll be talking about the future of vaccines. So without any further ado, we'll start with our first panelist. Next slide. Oh, I missed it. Our learning objectives. We'll go ahead and do those first. Although we are not doing CME for this, our learning objectives are listed here. We'll be talking about COVID-19. We'll be talking about choosing an appropriate test and identifying who's at risk, identifying risk stratifications and triage guidelines. We'll be listing medication options available and identifying associated limitations in urgent care. We'll analyze some recommendations and look at the vaccines and what their status will be. Next slide. Okay, testing who and when. Dr. Chow.
Thanks, Sean. Can everyone hear me?
Yes.
Great. Next slide, please. So the CDC has identified 5 categories where testing is appropriate. Individuals with signs or symptoms consistent with COVID-19, asymptomatic individuals with recent known or suspected exposure to SARS-CoV-2 to control transmission, asymptomatic individuals without known or suspected exposure to SARS-CoV-2 for early identification in special settings. Special settings would include nursing home workers. Individuals, previous slide, please. Individuals being tested to determine resolution of infection. However, on July 17th, CDC actually has suspended test-based strategy, which is no longer recommended, except in rare circumstances. Individuals being tested for purposes of public health surveillance for SARS-CoV-2. Please be aware that local and state health departments may offer additional testing guidance based on local epidemiological data. For example, in North Carolina, DHHS recommended that anyone who attended a protest also be considered for testing of COVID-19 or SARS-CoV-2. Next slide, please. I think there's some misunderstanding of what constitutes a close contact. We hear people come into the clinic and say, well, I was around someone who was around someone who may have had COVID. The CDC defines close contact as a contact within 6 feet of an infected person for at least 15 minutes without PPE, starting from 2 days before illness onset, or for asymptomatic patients, 2 days prior to the positive specimen collection until the time the patient is isolated. The second question that is controversial and the answer is unclear at this time is, when should you test an asymptomatic patient? If someone comes in and says, I was exposed, but the exposure was yesterday, the problem is testing is to determine viral load and to detect a virus. The early evidence suggests that a minimum of 3 to 5 days from exposure is needed for detectable viral load to develop. Test too early, you're going to have a false negative. Some other evidence suggests that even 5 to 7 days is needed from exposure before the test is reliably positive. The final take-home message today is that testing is not an unlimited resource. I realize that there are many recommendations that everyone should be tested. And if you look at the CDC definition, it is generalized enough that pretty much anyone who wants testing can justify being tested. But not every patient that presents to your clinic or presents for a testing center needs a test. And I think it's important to understand that you still want to talk to the patient and assess what the real need for testing is before blanketing ordering a test on everyone. Next slide, please. In terms of COVID-19 tests, what is out there? There are SARS-CoV-2 molecular tests. These are intended to detect evidence of viral infection or viral particles. There is nucleic acid amplification, which detects RNA, and this is considered the gold standard. These tests have the highest sensitivities of all the tests that are available. There is an antigen detection test, which detects SARS-CoV-2 surface proteins, i.e. capsular protein. They have high specificity, but lower sensitivity versus the nucleic acid tests. If negative and the patient is considered high risk, they may need to reflex to RT-PCR, and a negative test does not adequately rule out a patient who is at moderate or high risk. There's also the SARS-CoV-2 antibody test. These detect antibodies that the body produces in response to a SARS-CoV-2 infection. They should not be used as the sole basis to diagnose or exclude SARS-CoV-2 infection or to inform infection status, because it is unknown if the presence of antibodies convey immunity, and recent studies suggest that antibody titers may decrease rapidly. Next slide, please. Where are COVID-19 tests processed? You can either send them out to a private lab or state laboratory. Examples would be CDC, your state lab, or private labs such as LabCorp, Quest, etc. Unfortunately, increased demand in regions experiencing surge has resulted in delayed results of up to 7 to 10 days. There is also facility-based point of care testing. These have a high throughput. They can run hundreds at a time with fast turnaround time. Because they are sent to a hospital-based or a laboratory within your facility, you can get the results back pretty quickly. There isn't a send delay. but they are not suitable for ambulatory clinic. The most applicable test for ambulatory clinics or urgent care clinics will be a mobile platform point of care test. They deliver real-time results in 5 to 30 minutes. They are small portable units that are suitable for an ambulatory clinic setting. The disadvantage is low throughput. Unit can typically process only one test at a time. And again, a reminder that the antigen point of care is not as sensitive as a RT-PCR test, and negative tests may require reflex testing to RT-PCR. Next slide, and this ends the testing component.
Got to unmute myself. I apologize. One of the questions was about whether wearing a mask makes you less likely to be a close contact, and that is, if everyone's wearing a mask, then close contact is not considered the same with the mask on as opposed to the mask off. But now let's go on to our next panelist, Dr. Toscano, in basic principles of testing.
Great, thanks. Chris did a great summary of the tests that we have at our disposal, and I wanted to talk just a little bit more about the application of those tests. You know, just to review, when you think about the nasal swabs, whether it's an antigen test or a nucleic acid test, you're really just monitoring for the presence of viral particles or parts of the virus in the nose. And the antibody tests tell you that a person's been exposed and mounted an antibody response in the past. But it really doesn't tell us if they're actively infected or contagious. I think that depends a lot more on the history. And I'll talk a little bit more about that. We are hearing that these tests, how sensitive are they? How specific are they? They're designed to be fairly specific, meaning that a positive is indicative of what you're looking for, the presence of antibodies or the presence of viral proteins. Sensitivity, we're hearing, is kind of a little bit more variable. It depends on how the test is done, where in the infection process you're gathering the specimen. If it's too early, a person may be negative and then positive 2 days later. And even the numbers of those are ranging maybe in the 50 to 80% range in terms of analytic sensitivity. Complicating our decision-making with this is the fact that we have people who are asymptomatic or sick enough to die from the infection and everything in between. As well, there are respiratory kind of syndromes that can indicate that somebody's infected, as well as GI syndromes and rashes and kind of a bunch of weird stuff. The new mutation of this virus is probably more contagious than the previous version of it, the previous mutant. Luckily, there's lower levels of morbidity and mortality associated with it, but that contagiousness element, I think, makes us want to get this diagnosis right. I think when we're talking about what our goals are, that's when we need to think a little bit more about pretest probability, the test we're using, and what the result is. And that's going to really drive our diagnostic sensitivity and specificity beyond what the test actually does. In terms of our application of it, we need to consider all of this information as well as our goals. Next slide. So our usual goals in urgent care medicine are to arrive at an accurate diagnosis. And we want to do that so that we can institute a treatment if there is one. And most of the things that we diagnose, there are treatments, whether it's applying a splint or prescribing a medication, that's kind of our goal. In addition, we want to be able to counsel patients in terms of when they should be feeling better. And then also, if a condition goes on to be more complicated, we want to know what it is in the first place so we can tell our patients what to expect. In terms of COVID, there's a lot of emphasis on diagnosing the acute infection. I guess fortunately or unfortunately, there's no treatment. We don't have to make too many decisions about embarking on a therapy that could potentially harm a patient, but we want to counsel patients appropriately for isolation and follow-up. I find in my practice that we're doing not formal contact tracing like the public health department, but I think Chris alluded to it where, hey, I was exposed to somebody who was exposed to somebody. And so it's sort of this informal contact tracing that we're doing. Most of the time, those patients are asymptomatic rather than actively sick. We're looking to be able to counsel them appropriately for isolation. There's no post-exposure prophylaxis, so it's not super important to get that exactly right. And at this point, we don't have any vaccines to administer. So the contact tracing is relatively straightforward. I don't think in urgent care we're too much involved in surveillance, but there's a lot of testing involved in surveillance. Chris alluded to the nursing home situation where you'd actually test somebody who wasn't a contact and who wasn't sick, just to kind of get a feel for what's going on in a particular environment. And then he also mentioned a move away from the use of testing for return to work or other activities. It was actually getting very confusing, a lot of variability, employers expecting to have a bunch of negative tests before somebody returned to work. And when you consider the variability in the test results, it was really hard to feel like you were making a correct decision. Still, testing may come up in certain situations when you're trying to make a decision to return somebody to work, and that'll affect your diagnostic sensitivity and specificity. Relatively easy if you have a positive test. I think most of us are just going to go for the data that we have, that these tests are really specific, meaning that a positive test is a true positive. If you get a negative test, either an antibody test or a molecular test, antigen or a nucleic acid test, really how you proceed depends on the situation. And in some situations, you're going to consider retesting to confirm if you get a negative test result, based on what the stakes are. The next slide is a grid of our kind of basic decision making. We arrive at a pretest probability based on a history and a physical exam. And then we have a test result that's either positive or negative, whatever the test result is, if it's a nasal swab or antibody test. And when things align, which is the next slide, it's easy. You got a patient who you think has COVID and they have a positive test result, or you have somebody who you don't think has COVID or has no reason to have COVID, they haven't been exposed, and you have a negative test result. The interpretation here is, relatively straightforward. Next slide. A little bit more challenging when the patient could have COVID and you have a positive or negative result to interpret. I think we're being overprotective most of the time, and it probably doesn't hurt us to do that. We don't have a potentially harmful treatment that we're making a decision about. I think these patients with medium pretest probability and a positive test, if we were scratching our head really wondering, gosh, does this patient really have it? We're trying to make a decision about a therapy, it would be a little bit more challenging. It's relatively easy just to call that person positive. When they have a medium pretest probability and have a negative test, I'll talk a little bit more about that, I think, in terms of how we should probably think about that with another grouping here. Next slide. I think most of us are pretty content if we have a positive test result just to call the patient positive. It's not that true positive where everything aligns, but this is a disease where patients can be asymptomatic. And so what is a low pretest probability when this disease is circulating? I think for the purpose of counseling somebody to isolate and then have the patients who they've been exposed to or the individuals they've been exposed to tested as well for contact tracing, it's probably not a bad thing, even though some of those are going to be false positive, just to consider those patients positive. Lump all of these together with our true positives. There'll be some overdiagnosis here, but the harm is probably relatively low, particularly because there's no anti-COVID stewardship yet in terms of medicines and things. Next slide. I think similarly, if you have a patient who you think has COVID, they've, maybe more than just an exposure or not an exposure, but they have some symptoms. And they have a negative test. I think if you really think the patient has COVID, we have a better feel for this now than we did a couple months ago when we were trying to figure out what a patient with COVID actually looked like, particularly with flu still circulating. If you think the patient has COVID and you have a negative test, consider that a false negative. If it's an antigen test, particularly you want to send a nucleic acid test for confirmation on that patient. I think if they have medium probability and you have a negative test, it could be that they're negative, but I think a lot of people are considering both of those potentially false positive, being, again, a little bit overprotective of the situation, and having the patient isolate and consider retesting in those situations probably makes the most sense. All right, and then next. Next slide, please. Sorry. Good.
Okay, thanks, Dr. Toscano. Next on our list, Dr. Bogle will talk about treatment and care.
Thanks, Sean. And thanks, Joe and Chris, for a great job of explaining the testing, which is obviously the most important component of COVID-19 right now, and especially in urgent care centers. My part of this talk talks more about, you've done the testing, now you kind of come back to the whole clinical picture of this patient and decide what to do with the patient eventually, right? So if the testing is done, it's positive, or, let's say it's positive, a patient does have COVID. What do we do from there, right? So the biggest, I'm just going to highlight some key clinical pieces that I see clinically, when working in our urgent care centers. I was working yesterday. Some of these came up as well. So the challenge is, how to identify at-risk patients. And if you go through the list, showing in front of you, this is not rocket science for us, right? We consider all these entities as high risk for a number of other medical issues, or for a number of other infections. Patients who are 65 or more, years of age, living in nursing homes or any long-term facilities. If they have any cardiovascular disease, diabetes, puts them in an immunocompromised states. So does cancer. If they have any respiratory illness, they're obviously going to be at higher risk than the other general population without this illness. So after we have identified these high-risk patients, next slide, please. Next slide. I guess the biggest challenge that I see clinicians facing, I myself was facing initially at least, was how to determine whether we can discharge this patient safely back home, and with quarantine instructions from our urgent care site, or do we need to send this patient to the emergency room? I feel that's kind of the biggest challenge that I see a lot of clinicians facing. And so to help with that, the College of Urgent Care Medicine actually worked with the American College of Emergency Physicians, ACEP, to develop this risk stratification and triage guideline/tool, if you will. And the idea was to have two big categories. The first and the second category are the big categories that help define that whether you can send the patient home versus do you really need to strongly consider having this patient go to the emergency room. So if the patient is symptomatic but clinically appears well, the resting pulse ox is more than 94% at sea level, there's no desaturation with ambulation, so it's not falling to 93 or below, and there's no obvious signs of tachypnea, more than likely you can safely send this patient home with really good discharge instructions, talking about what to do in quarantine, talking about the red flags they need to look for at home, and in case they do develop those, going to the emergency room. Versus if the patient is symptomatic, but appears toxic or in distress, they have low pulse ox, they are tachypnic, they have a low blood pressure, or the systolic is less than 90, diastolic is less than 60, or if there's an obvious change in mentation or they're tachycardic, you might want to really consider them sending to the emergency room. And if you look closely, these criteria are not limited to COVID. Any person who will be in some kind of distress because of any illness, it could be sepsis, it could be anything, it could be ARDS, you really should be considering those patients anyways to go to the emergency room. So that's why we try to kind of just simplify these two categories so that it's not a whole lot of, combinations and permutations of who goes and who does not. Hopefully this is helpful to everyone who uses it. And the third category is consider transfer to the emergency room, right? So these are patients who are 60 or more years of age, who have other comorbid conditions. These are the patients in whom the decision to whether to send them home safely versus sending them to the emergency room might be a little more complicated. And it will depend on what other signs and symptoms they are showing as based on category 1 and category 2. So if someone who has a history of diabetes but is otherwise well appearing, you do a rapid blood sugar check in the office, it's normal, within normal range, they have good PCP follow-up, you're not concerned about a pneumonia or something, probably they're safe going home. Versus the same patient, if they are desatting, or have change in mentation or any of the other clinical presentations mentioned in category 2, you probably want to send them to the emergency room anyways, right? So just a higher risk category of patients in which we just need to be more careful than others in terms of making that determination. Next slide, please. And I just want to also talk about some of the common medications that our colleagues ask us whether they should be prescribed in an urgent care or an outpatient setting or not. And also, surprisingly, I'm seeing a lot of patients ask these medications. Can we go to the previous slide? Yeah, thank you. So even the patients are coming in asking for these medications because they are reading it on the internet. They are hearing these medications on the news. So I just wanted to kind of, I thought it would be nice to kind of just talk a little bit about them. And the guidelines that we decided to use were the National Institute of Health COVID-19 treatment guidelines, which are suggested by the CDC as well. So first and foremost, there's no FDA-approved drug for the treatment of COVID-19. So if someone comes and asks, saying that they found a new drug, hang on to those shares, buy those shares. I think you have something on your hands at that point in time. We do not have an FDA-approved drug. Dexamethasone, we all keep this medication in our urgent care at our urgent care sites. Typically we keep it for kids who come in with croup. You're giving in dexamethasone, and for some other reasons as well. The NIH panel still recommends against using dexamethasone in patients with COVID-19 who do not require supplemental oxygen. Think about it a little more. If a patient is requiring supplemental oxygen in your urgent care site, you're probably not going to be sending them home anyways, right? So this is not a medication that you would probably be thinking of as in terms of the first line treatment for someone who's in acute distress and whose oxygen is dropping. You're probably going to be putting them on oxygen, calling 911, making sure that they are stabilized before the ambulance arrives. So there is some use for this medication. I personally feel that we should not be prescribing, giving this medication in an urgent care setup. In a few days, weeks, months, we might get to that point, but not right now. The other common medications that patients ask about are statins and ACEs and ARBs. So currently, and again, the NIH panel recommends against the use of these treatment modalities for COVID-19 outside the setting of a clinical trial. ACEs and ARBs, ACEs predominantly came into limelight because it seems that the receptors on the cell, the ACE2 receptors on the cells, are the ones that the virus binds with in order to enter the cell. So the idea was, if we can use ACEs against them, that might be a good way of preventing the virus from attaching to any cells of the body. Again, still in the clinical trial phase, no conclusive evidence whether we should be using them. Next slide, please. NSAIDs, they have been in talk since day one. I think there was a study out of France initially that was suggesting that we should not be using NSAIDs in patients with COVID-19. There is some evidence now, at least, that there's no difference in the use of antipyretic medications when it comes to either acetaminophen or NSAIDs between patients with or without COVID-19. So we can fairly comfortably say that you can use these medications. Now, if the patient was already using an NSAID for some comorbid, chronic condition, the recommendation from the panel is to continue with that treatment. We really do not necessarily need to stop that treatment. Same thing with chronic corticosteroid use, right? So if someone's been using corticosteroids for other underlying conditions, such as adrenal insufficiency or other rheumatologic problems, unless specified by their primary doctor or rheumatologist, or you feel a genuine need to stop the steroid because of a major contraindication, when you see them, they can just continue with those medications. Inhaled corticosteroids is another question that I see providers asking and patients as well, that whether they should stop using inhaled corticosteroids if they have COVID-19 or develop symptoms like those. And the panel recommends against stopping these medications, again, unless, again, you feel clinically that there is something that really that will, cause an issue. But for the most part, the panel actually recommends that you can continue using these medications. Next slide, please. And before we go to the next part where Joe's going to jump back in, I just wanted to also talk about a few other things that actually came up at a clinical shift yesterday. I had a patient come in who talked about, hey doc, should I take vitamin D, vitamin C, zinc, to boost my immunity so that I don't get COVID-19. This was for a different issue that the patient had come in with, and it was an interesting question. And I actually went back and researched. There's actually there's insufficient evidence, it seems, to prove, to say for or against the use of these vitamins and minerals in terms of treatment and prevention of COVID-19. I guess the recommendation would be, if someone needs to take vitamin D anyways because of their low vitamin D levels, they probably should continue taking those. So we're entering a little bit of a primary care realm in this topic right now. But if they ask you that question, the answer should be, the NIH guidelines again clearly say there's insufficient evidence, meaning that they do not know whether there's any risk or benefit, and I guess consequently we do not know if there's any risk or benefit around these medications. So if they take a daily vitamin just because, I guess they can keep taking it. They don't need to take 5 pills instead of 1 now. Nothing magical is going to happen. So with that, I'll end my talk. Thank you.
All right, now to Dr. Toscano again to talk about what we fear, the fall.
Hey, I think we're going pretty well with schedule. I wanted to actually talk about a couple things real quick before I get into this. Hopefully we have some time. About a week or so ago, there was a physician from Texas who was talking up inhaled corticosteroids as a treatment for COVID. I don't know how many, there were millions of views of that video. He was on YouTube. He was interviewed by a talk show person in Dallas. And it actually prompted me, Jazz talked about not stopping corticosteroid inhalers in patients who are already using them. And there's a lot of data about that, that's not harmful to continue those, but I could not find anything about the use of inhaled corticosteroids, particularly he's talking up budesonide by nebulizer and having, 100% cure rates or 100% treatment success with that. And I was not able to find anything about any clinical trials or any benefit to that medicine. And I haven't had patients talk to me about it. I've been anticipating having patients say, hey, can you prescribe me a nebulizer and budesonide? And I don't know, are the other panelists seeing that at all as a result of that video? It was recorded on July 3rd, so that was 2-3 weeks ago.
I've had a couple of patients ask specifically about that. That's kind of, I was going to research anyways for the presentation, but yeah, that prompted me more.
Yeah.
I haven't. Chris?
I have not had anyone ask me about that to date.
How about you, Tracy? You're in the hotbed of Florida. No.
First time hearing of it.
Okay. Maybe it's just in Texas. I think he's also running for Congress, or he did in the past. And I don't know anything about the individual, but anyway. And then the other thing, I saw some things just pop up on the chat. I don't have the chat open, but community prevalence of the SARS-CoV virus or COVID infection is definitely part of your pretest probability. It specifically is part of your pretest probability in somebody who's entirely asymptomatic. So if there's no COVID in your community and somebody's asymptomatic, there's really no reason to test them. Their probability would be low. But if your prevalence in the community is high and people are out and about, particularly if the sense is that they're not being careful when they're out and about, that does increase the pretest probability of particularly an asymptomatic patient. It also affects the pretest probability of a symptomatic patient. I think we were seeing people with respiratory infections early on and had negative COVID tests because they had some other virus. And now, particularly where there's not a lot of other circulating viruses, when you're seeing patients who are symptomatic, if the prevalence is high, that does increase the chance that that person would have the disease. And likewise, if there were no COVID in your community and they have respiratory or GI symptoms, their pretest probability may still be low. In dealing with known close contacts of somebody who's positive, that really doesn't enter in too much because, I guess they could have other exposures as well, but there's a, kind of a distinct medium pretest probability associated with being asymptomatic, but a close contact of somebody who was positive. So hopefully that kind of explains that. Okay, so I think this came up on the listserv as a kind of a topic and something that might be frustrating for folks as we get back into flu season with COVID still being in the mix of the patients that we see. What are we going to do? How are we going to deal with this? You know, I think the protections that are still taking place, PPE and all of that, are going to continue. We probably won't go back to a mode where how we used to deal with flu patients, which was pretty much, I don't know, no protection. Maybe we should have been a little bit more careful with that. But I think we'll see that the protective mechanisms in cleaning rooms and all that kind of stuff is going to continue. When you look at some of the similarities between these infections, you know, they're all respiratory tract infections, so the symptoms could be common. You could have somebody come in with fever, cough, sore throat, or at least fever and sore throat, and they could have any one of these diseases. We're used to testing for flu and strep. We're used to the variability in test results and factoring in kind of false negatives when we get them if we really suspect that the infection is there. But those tests are perfect. I think we're learning that the COVID tests are maybe even more imperfect, so we have to kind of deal with that and factor that in as well. But again, if you just go back to the basics that we all learned as clinicians, the history and physical are key. They're going to drive a pretest probability that's going to help us use our tests and make a diagnosis. And then epidemiology can help quite a bit too. If flu is really prevalent in your community and COVID isn't, it's going to help you make some decisions. If both diseases are prevalent, that kind of pretest drives your pretest probability, also that epidemiologic knowledge. But there are differences. You know, I think, unfortunately, during the really busy season, somebody with fever and some cough and sore throat ends up walking in the door and getting both a flu and a strep test. And then we, you know, kind of drive our decision making based on the results that we have in our hand at the time we're seeing the patient, when maybe that's a little bit backwards in terms of how we should be making decisions. And really, truly, strep pharyngitis is a very isolated illness. It's not influenza-like if you really think about myalgias and cough, particularly once you get down into that respiratory tract, that part of the respiratory tract beyond the throat. So, you know, using something like a Centaur score, using your history and exam to looking at the throat and seeing if it's red. I don't know how we're going to do that with COVID. You're just going to take a quick peek. But that's going to help us make a decision of strep versus some of these other infections. And I think, you know, again, fortunately or unfortunately, we don't have a treatment for COVID. So overdiagnosing it is not necessarily going to be a bad thing. It's not going to make us treat patients inappropriately, and it may just make us be a little bit more careful when we maybe should have been careful even in the past. And I think because, you know, this disease is probably worse than flu in terms of the overall damage that it causes, I think that overprotectiveness is going to be okay for us to kind of have in the mix of how we take care of these patients. We learned last year that co-infections do occur with flu and COVID. We know that COVID and strep infections can co-occur as well. So that's going to drive how we handle this. I just have one more slide to kind of put it all together. If you have somebody who's flu, strep, and COVID positive, I think we're going to just call them all the same. We're going to, you know, unless you look in the patient's throat and you really don't think they have strep, I think this is relatively straightforward. You're going to talk to the patient about treatment for flu if they're a candidate, and if it's appropriate to treat them, you would go ahead with your usual treatment for a strep infection, and then counsel the patient on isolating in terms of their COVID infection, and, you know, being careful at home, and probably having their contacts traced back as well. If you have a patient who your pretest probability tells you that the probability of strep is high because they have a high Centaur score and they don't have a lot of systemic illness, and you get that positive strep test, but the flu and the COVID tests are negative, that's pretty straightforward too. You can kind of believe that and rely on that result. It validates your clinical impression when you think clinically the patient just has strep. Likewise, if you happen to get a strep test that's been done, you may not have done it because you didn't think the patient had strep, but that strep test is negative. You have a patient with more systemic illness and the flu and the COVID are positive, you're going to proceed similarly to those other situations. Make a determination whether the patient needs to be treated for flu based on the duration of illness and the risk factors. And then again, if we don't have a COVID treatment, it's just going to be a matter of isolating and contact tracing because of that. If you have a situation where the patient does have systemic illness, kind of an influenza-like illness, regardless of their strep result, the situations that may be a little more difficult are if their flu is positive and their COVID's negative, because there's so much overlap in the symptoms. Are you going to believe that? Is that a false negative COVID test? Or what about if their flu is negative and their COVID is positive? I think this is really where we got to think a little bit more about what our approach is going to be. And I think, again, being a little bit more, the pretest probability is important. If the person's been at home and just exposed to the flu, you could probably believe that flu positive, COVID negative. But I think we probably overtreat flu a little bit when we consider the possibility of false negatives. And so we may end up just treating these patients for flu and having them isolate for COVID. And it's probably the case that those same isolation principles for COVID would probably help us decrease the burden of flu. I think rapid tests are going to help us sort through this a lot more quickly. Delayed COVID results just delay the diagnosis. And I think, again, probably the most important thing is really to not have COVID and flu tunnel vision this season. I just had a patient, actually my last shift, that ended up having pyelonephritis, who had headache, body aches, nausea, and was concerned that she had COVID. We sent the test, but then in going through and doing a little bit more of an H&P and actually getting urinalysis and some blood work, she had pyelonephritis. So if we limited ourselves and just said, okay, we sent your COVID test off, why don't you go home and we'll see what the result is, a potentially treatable, very important diagnosis would have been missed. So I think we got to keep that in mind. And then again, I think one of the biggest advantages this year versus last, even January or February, is we've had some experience with COVID now. We have a gut reaction. That's what our pretest probability is. Do we think the patient has it? What does our gut tell us? And in any situation where our gut doesn't agree with the test results, you really have to go with your gut. And unfortunately, it seems like things like procalcitonin and CBC really are not going to help us in this mix of diagnoses. They probably don't help us with much anyway. So we're just going to have to decide on pretest probability and use our tests smartly.
Thank you, Dr. Toscano. Trust your gut. I think you told me that 10 years ago, and I've been doing it ever since, and had a real positive results from it. Next, the future and the things we really want to know. Tracy, can you talk to us about vaccines?
I just want to add one thing. Oh, thank you, Sean. And very good, everybody else. I just wanted to add one thing on Dr. Toscano. I actually had a patient who presented. We actually schedule appointments for COVID testing. And so it's assumed before the patient even walks in the door that that's what they're there for. So the nurses pre-swab them before we even see the patient. So I go in to see the patient and I ask him, why were you getting tested? And he says, well, I think I have COVID. So, I went through all the history and stuff. And then I asked him, how long he'd had symptoms. And he says to me, off and on for 4 months. And I was like, wait a minute, that's not COVID. In the end, it turned out he had really significant hypothyroidism. And if I had missed that question, or if he had answered, 3 days, because that's how long it had been on before it had been off and on, I would have had the COVID tunnel vision, and I would have completely missed the hypothyroidism. And, who knows how long it would have been before he had gotten proper treatment. So I know it's extremely difficult when we start adding in common cold and strep, and I had one that was mono the other day. But you got to keep your guard up. Yes, definitely go with your gut. That's served me well for 30 years, but you got to keep your guard up and make sure that you don't have COVID tunnel vision. Here in Florida, 90% of what I see is a COVID concern. So I have to make sure that I'm not missing that other 10%. Okay, so future of vaccines. This was kind of a really difficult thing to write. I wrote it 3 weeks ago, and it's probably changed 4 times since then. I added another slide, and I actually read something this morning that I need to add to it that's not in the slide, so I'll talk about that in a little bit. But when I first started writing this as of June 30th, there were over 120 investigative new drug applications just for vaccines. This is not for treatment. This is only for vaccines. I mean, that's just staggering thinking how many people are working on this right now, and over 70 different companies around the world. There is a authority, kind of a consortium, if you will, called the Biomedical Advanced Research and Development Authority, or BARDA, and they've dumped $2.5 billion into 5 pharmaceutical companies and tasked them with coming up with a vaccine. We have several phase 3 trials, which will be many trials that are currently, there's a phase 3 trial launching in July, the end of this month, that'll have about 30,000 subjects in it. I actually have friends in upstate New York where there's a testing area there that have all signed up for it. Do not expect any FDA approval on any of these vaccines. All of them, just like our tests, are going to be emergency use authorization only. It takes about 5 years, if not longer, for a vaccine to be approved by the FDA. So if we want to see a vaccine before 5 years, then it's going to need to be emergency use authorization only. There are several candidates that some of these companies are hanging their hats on and assuming they're going to work. And they are mass producing them what's called at risk. What that means is we're hoping it's going to work. We think it's going to work. We think it's not going to have side effects. And we're going to start manufacturing this now in the hopes that it's going to get that it's going to work and we're going to get emergency use authorization. I mean, I just can't even imagine how much money they're putting in this at risk. Protection will likely be incomplete. Think of it like your flu vaccine. It's not going to 100% protect you from the disease, but it will confer some immunity and hopefully prevent you from getting moderate to severe disease. So, all those people that say the flu shot doesn't work, well, the COVID shot probably isn't going to work either. It's going to just dampen the effect the virus will have on your body and make you less sick than you would be if you didn't get the vaccine. And it will likely only protect for several years. So this may be something, if unfortunately COVID stays around, we may have to have multiple vaccines every few years. It's also likely going to be a 2-step vaccine process where you get one vaccine, you get one injection, and then 28 days you have to get a booster injection to give you enough of the antibodies to actually protect you against the disease. So look for that we're going to end up having to have two injections. Next slide, please. So here's just a list of the top candidates for vaccines right now. The top one in the USA, which is the third one down here, is Moderna, which is also being I don't want to say co-sponsored, co-developed by the National Institute of Health. It's actually an mRNA vaccine, meaning that they're giving you some mRNA that's similar to the COVID's mRNA that's going to cause antibodies against that. They just finished the phase 2 trials in that, and it's looking pretty good. Phase 3 is supposed to start any day now. It did look like it was going to be an effective vaccine. There's another one from the UK. Let me see if it's on here somewhere. Yes, the second one down is the UK of Oxford, and that just was published yesterday. It just completed its phase 1 and 2 trials. This one is, they took an adenovirus that causes colds in chimpanzees, and they massively altered it with genetic engineering. And what it's going to do is cause antibody and T-cell immunity against the COVID virus. This virus is not infectious for humans, so we don't have to worry about getting a disease from it, thank goodness. Again, you're going to have to get 1 to 2 doses. Right now, they're saying that they compared it with the meningitis vaccine, so their control group were people that were getting meningitis vaccines, and there were no more side effects or problems with it than they saw with the meningitis vaccine. Let's see, and they studied so far 1,077 healthy adults. One of the big problems with developing vaccines for here is they don't know how, quote unquote, strong to make the vaccine. The problem is we really don't know enough about this virus yet. And you know, most diseases have to be studied for 10, 15, 20 years before you can even think about developing a vaccine for it. And here we are 7, 8 months in, and we're trying to come up with a vaccine against this disease. Some of these trials, they're being built on some of the work that they did against MERS and the SARS that was through Asia quite a few years ago, that they had started to work on vaccines, but then when the disease sort of died out, they kind of stopped. So they picked up some of that based on this, because those were also coronaviruses. But just looking at how many, and these are just the top ones. I mean, there are just so many. Hopefully we'll come up with something sooner. Next slide, please. So there is a thing called Operation Warp Speed, and this was developed by the White House, tasked with developing the vaccine by the end of 2020. That's probably not feasible, but early 2021 probably is feasible. Not only does Operation Warp Speed kind of push for vaccine manufacturing, but it's also looking into, once we get this vaccine, what are we going to do with it? How are we going to get it out to the population? Who deserves it? Who's going to get it first? Who's going to get it last? They're expecting 300 million doses to be produced by 2021. And again, they're doing this at risk. So the top 3 or 4 vaccines that they're working on now, the companies are mass producing them, hoping they'll pan out. They're also, this Operation Warp Speed is also addressing supply chains for syringes, raw materials, even stuff as silly as alcohol pads, to make sure that there's enough of this stuff to manufacture, distribute, and administer the vaccine. One of the ideas that's come up by the White House is to have a non-government agency oversee distribution. Right now, the top candidate for that is the National Academy of Medicine. This way, it'll be a non-political thing to decide what groups get vaccines and what order. This way, all groups will be equitably benefited and represented. It will more than likely be that healthcare providers will be vaccinated first, because they need us to take care of all the people. And then the highest people at risk will be next, likely the elderly, people with chronic diseases, the immunosuppressed, anybody who's more likely to get severe disease will probably go first. And then you can expect young, healthy people or people in areas where there isn't a lot of COVID will probably go last. There's a lot of talk, the Hispanic and Black communities there's a lot of issues with them. There's higher rates of COVID in them than there is in other people. So the thoughts are that perhaps those groups should be vaccinated first before some of the other ones at risk. We all know how political some of the stuff has gotten over the last few months. So they want to make sure that all vaccines are distributed equitably to all people, so that everyone gets the vaccine in a timely fashion. Urgent cares really need to be a part of this distribution plan. This is really a great opportunity for us as an industry to step on here. We certainly stepped on the testing bandwagon, and we should also be on the distribution of the vaccine bandwagon. It's my understanding that the Urgent Care Association is looking into this to make sure that we won't be left out of the plan, and that we will definitely be a part of vaccine distribution. Next slide, please. Oh, we're done. I'll turn it back over to Dr. McNeely, and he will field and distribute questions appropriately.
Thank you very much, Tracy. Not the exact answer I was looking for was like we have a vaccine in a week and we're all going to be 100% protected, but we knew that wasn't going to be the truth. We've been around too long for that. Lots of questions out there. I do want to start with mentioning that UCA has a test list. You can get yourself listed on the group of people who are doing testing. So if you want to have your urgent care center listed, make sure you get in contact with them. It's important that we can be on that ban list. My guess is we'll probably be using similar lists to start talking about vaccines if and when they ever do come out. So the first question we had, and I'm going to direct this actually to Dr. Toscano, close contacts and mask type. When we were talking about close contacts being at risk, does the mask type important? Are we talking about a surgical mask? Are we talking about the cloth things? Or are we even talking about the mask worn around your neck that looks like a bandana?
Yeah, I think so a close contact's defined as unprotected. So it would be, I think the CDC definition. So, and in 15 minutes, closer than 6 feet. So it's usually somebody in the household. You could say, I guess, if you were wearing an N95 constantly around that person, you might be safer. Or if that person were wearing a surgical mask the whole time. But I think the CDC definition of a close contact is unmasked.
Excellent answer. And
Yeah.
going around all those big questions we have out there. Antibody response. There was an article that someone mentioned about the antibody response in IgG. Dr. Chow, can you talk about what we're seeing with response to having had the disease and the antibodies being present or not, or if that's always happening or usually happening?
Yeah, I think that there's just too much uncertainty about this issue. The one study out of Asia suggested that 80% of antibodies were undetectable or diminished after 3 months of time. There are some other studies that show other results. I think the other question is, great, you have antibodies. Does that mean that the antibodies that you produce will prevent a second infection or not? Or if the antibodies that we're picking up on testing is specific to SARS-CoV-2, or is it a cross-reaction with another coronavirus that's a non-SARS virus? I think that there's just too much uncertainty at this point to have clinical implications of an antibody test. The other issue is that we also don't have quantitative tests of antibodies at this point, so we don't know what levels convey immunity and if it does even convey immunity at all.
Thank you very much. Really important. Yes, not only is it there, but what does it mean? And we don't know that. I think, unfortunately, that's what we're running into a lot is we don't know what the answer. We know the answer, but we don't know what it means yet. And applying that generically could be a problem for us going to the future. Dr. Bogle, return to work. Apparently, there was an update recently on the 17th. Are you familiar with that?
Yeah, even I've just heard about it. Return to work, by the way, it's a huge topic. That we also covered in our last town hall, right, Sean? Just to confirm, yeah. And any of the panelists, please correct me if I'm wrong. I think the new recommendations is that instead of 10 days, it's 7 days now across the board, and being asymptomatic for 24 hours. Is that correct?
That's what I'm hearing as well.
Yeah, so it's the same thing. Yeah, but that's the new recommendations.
Chad?
Yeah, go ahead.
They also have strengthened the length of time for those with severe disease as well as those who have immunocompromised state, that they now want 20 days from the onset of symptoms before return to work. And the other big piece of it is that the test-based strategy, the 2 negative tests using a RT-PCR for nucleic acid, is now no longer recommended. It's all symptom-based return.
Mm-hmm. Yeah. And that's what thanks, Chris. And that's what we've been doing, or trying to at least do in our area, using the symptom-based criterias and trying to convince employers as well that that's probably, in their benefit. So yeah, thank you.
We've seen a lot of people being requested to get multiple tests to go back to work. I've also seen positive tests 21, 28 days out a long time ago when we were testing everybody till they got negative. And that really didn't seem to have any effect. People had 3-4 days of disease and were testing positive at 28 days.
Yeah.
And then this whole idea that their 3 tests are positive, or employers saying that we should test people every 3 days or every 2 weeks. None of that has any base in science. And so when we start doing that, we start to get these community ideas. This is how we do it. But when there's no basis in science, we realize we really haven't helped ourselves. And as everyone has said, there's a limited number of tests out there, and to use them for something that's not helpful is just that, not helpful.
Yeah, the viral load
Sean.
setting can continue for months, right? That's what we are finding out now. So, a positive, without symptoms is kind of meaningless. So yeah, absolutely. I've even called employers and talked to them and say, hey, you know what, we can do the testing if you really want that, but realize that the test results will not be back for another week or two now, given the backlog. And do you really want to keep your employer out that long when I can clearly give you the CDC-based clinical guidelines saying that, yeah, that your employer can actually come back to work. More often than not, they kind of agree that, oh yeah, let's just do the symptom-based criteria than the testing one, because there is a financial implication that the employers face as well if their employees are not coming back. So that's one way I've been kind of talking and trying to get the message home to them. Yeah.
Yes, I just looked it up. It's 10 days if you weren't that sick, 20 days if you had severe illness, but at least 24 hours since some symptoms have passed without a fever and cough and shortness of breath improving.
The other thing that's implicit in return to work is that you should be returning to work in an environment that involves social distancing or mask wear if you can't. So it's not like going home and being with your family and being close with them. When people do return to work, there's an additional safeguard. So, I think people say, well, what if they are still positive, or what if they are still infectious? Your buffer cushion for that is the fact that you should be social distancing in the workplace. And if not, people should be wearing masks. So that also reduces the chance of these, what if there's a miscalculation here?
So we've hit the 3 o'clock hour. I don't want to keep anyone past when we promised them we'd be here. So I'm going to hand it over to Laurel Steimanoff to kind of give us some final thoughts.
Sure. Well, this does conclude today's town hall on COVID-19. We will, right now we're planning to have at least one more. I want to thank our panelists, our facilitator, our attendees, and have a wonderful remainder of your day.